We are Group Green 3A. I'm Shazia Firdaus.
Brooke Boylan,
and Alyssa Berger.
Today we are going to talk about current state of ACOs integrating care for substance abuse with primary care. That's a lot to say at one time, right? Well, let's break it down to see what it means. Accountable care organizations, or otherwise known as ACOs, are essentially integrated groups of either physicians, providers, or any other healthcare professional who come together to take full responsibility to improve care, quality of care, cut costs, as well as improve overall health of an entire population or defined population. With that, ACOs are working with primary care in order to do that. And today we are going to talk about cost, access, and quality, which are all overall themes we have discussed in this course.
Despite what we may think, ACOs integrating with primary care is not a new concept. In fact, our textbook verbatim describes these new organizations that may turn out to be nothing more than old wine in new bottles. Well, what makes this so? First of all, it has very similar qualities with integrated delivery systems, such as managing diseases or maintaining disease and health status, coordinating costs, cost shifting, reducing costs with certain physicians or other allied health professionals, as well as the utilization of information and technology. So what makes this different then? Well, first of all, Medicare is trying to, and has approved by the ACA, been able to establish delivery as well as reimbursement and payment methods with the accountable care organizations as of 2012. And the main difference is because these ACOs are dependent upon how well they do in cutting costs and improving quality. Now that we know what the ACOs are doing and integrating with primary care and its purpose, why is there a focus on substance abuse? Well, according to the Journal of Health Politics, Policy, and Law, in order for the accountable care organizations to improve the cost and quality the most within the largest population in the United States, there needs to be an emphasis on the substance abuse population because there is a very large number of individuals, unfortunately, within our country that have this issue. And along with this issue, this goes back to the topic of comorbidity and chronic, the shift from infectious to chronic. Why do that? Well, in the long run, it cut costs. So this is why individuals are focusing on these people, because this is going to allow a shift, and focusing on chronic diseases is ultimately going to lead to the most improved, efficient quality of care. Now that we understand the importance of why we should cover substance abuse within integrating care and why the ACO is also doing this, we need to understand that primary care is not what it used to be. It is now becoming more specialized, and its emphasis is more on other services that also improve the quality of care and survival for individuals, such as individuals who have chronic illnesses. And according to an article provided by the Health Affairs, integrating these services, however, it still remains low. Why is that? Why is the ACO still continuing to try to go to more traditional services? And why is these innovative models or implementation of integration so challenging? Well, just like you see in this picture, in order to make change, it involves a lot of hard work. And just as we've been learning previously, cutting costs and improving costs and access to quality is a long process, and it takes time.
Different research articles addressing ACOs pursue innovative models by Health Affairs and PubMed have similar purposes but have different methods of study. In some of the research papers, mixed methods research designs were used. This way, the researchers have examined the extent to which ACOs are clinically, organizationally, and financially integrating behavioral health care and primary care. Survey data was also used to quantify the involvement of behavioral health care providers in ACOs and the integration of behavioral health treatment and primary care. For this purpose, data from 257 respondents to National Survey of ACOs was used. Afterwards, the data was supplemented with semi-structured, in-depth interviews with clinical leaders at 16 ACOs purposively sampled to represent the spectrum of behavioral health integration. These research papers revealed that most of the ACOs were responsible for some behavioral health care costs, and only 42% of them actually include behavioral health specialists in their providers list. Moreover, a senior administrative leader as a respondent was targeted at each ACO. Out of 409 eligible organizations, only 270 have completed the survey. So, only 257 organizations have provided the complete data. ACOs were surveyed on different domains, including contracts, organizational structure, providers, and infrastructure. Lastly, ACOs were asked to indicate the highest level of engagement they had with behavioral health care provider group, and for that they were provided with three options. For instance, the groups were within ACO, outside the ACO with a contract, and the third one is no formal relationship.
While there can be numerous advantages to having ACOs, there are also issues. According to our book, there is a lack of clarity amongst three main issues. First, there is worries that smaller physician offices will not be able to reap benefits from ACOs but have to comply with stricter regulatory rules under the ACA. Secondly, we do not know how safety net providers like public hospitals and community centers will be included in ACO organizations. Lastly, ACOs could possibly run out of competitors, and this could cause an increase in prices and lower quality, which is opposite of what the ACOs are trying to do. This is relative to our topic because if ACOs are having structural and regulatory issues to begin with, it is going to be harder for them to be successful in integrating any sort of primary care to reduce substance abuses. These three issues can be potential barriers for ACOs being able to accomplish their goals. ACOs are at a relatively new stage of development. This allows for many barriers and limitations along the way. Substance abuse and mental disorders fall under the category of behavioral health disorders, which unfortunately a lot of times go untreated, which can be costly for the healthcare industry. Many ACOs currently do not include behavioral health professionals in their networks. This causes even more individuals with substance abuse problems to go untreated. There has been much talk lately about making standalone non-network behavioral health providers as clinical resources for patients. Also, another solution is preventative treatment by spending more time to train healthcare providers on preventative measures such as preventing the onset of substance use and limiting the development of substance abuse.
Discussion questions. Question 1. What challenges do you think ACOs will face in integrating this type of care as our healthcare system, and rules with the ACA continue to change? Question 2. What type of management within these providers and allied health professionals is needed to improve integration of these types of healthcare service? Thank you.